Hello, this is Dr. Mike Stoner bringing you November's MEC Minute. Today we'll talk about the 2020 updates to the Pediatric and Neonatal BLS ALS guidelines. Last month, Dr. Z went over the adult guidelines, and we'll catch up on the pediatric part. All right, so what are we going to go over today? We'll talk about the guidelines that were just released on 10/20, as I had mentioned before. We'll highlight some of the updates, some of the guidelines that have been updated. Couple key points. They talk a little about the respiratory rate, make a new statement on cuffed ET tubes, and they kind of emphasize a little bit of earlier epinephrine. And then we'll talk a little bit about parts you might want to change in your practice of how we're doing things. I will give full disclosure, and I stole this slide from Dr. Zeeb, but this is something the American Heart Association has stressed upon, and it's kind of their strength of the recommendation. So they have their class COR, they call it the class of recommendation, and they also talk about their level of evidence. The class or strength of recommendations, they kind of talk about class 1, 2A, 2B, 3, and then some parts that are actually cause harm. And it kind of goes as to what they strongly recommend or moderately recommend, and you can read there, but it just talks about different evidence that's there. And then the level of evidence, they have an A, B, and C, and the A has some high quality evidence, usually some randomized controlled trials that have done good work to prove that it's right, maybe a meta-analysis or accumulation of a lot of different studies that have been done that somebody will go by, they'll pull multiple studies and kind of look at the evidence from there and come up with a statement. The level B, they have BR, which is randomized, and BNR, which is non-randomized, and those can be other studies that may or may not be some randomized control trials that have good evidence or moderate evidence, I guess, not great, or some meta-analysis, whether it's from randomized or unrandomized. If it's unrandomized, that would be a level B NR. And then C is limited data on a CLD, they call it. And then finally, the last level, CEO, is expert opinion. That's just a group of people kind of giving their opinion, not really having a lot of evidence behind it. It's just, we've always done it this way, so that's how we're going to do it. So this is actually used throughout the whole. American Heart uses this a lot, and then we'll bounce across it throughout the presentation here. The one thing I will mention is if you look as we get through this thing, you'll notice that there are some strong recommendations of using things, but a lot of the evidence behind it is lacking, and I think that's been that way since forever for a lot of the American Heart and a lot of the resuscitations. And you'll see that in the fact that they change it every so many years is because the evidence that it's there is not great or it's always changing. This was also brought upon in the adult lecture last month, but the chain of survival is also there. There's 6 links. The 6th link is new in this round. You'll see they qualify it as in-hospital resuscitation, out-of-hospital resuscitation, the top being in-hospital and the bottom being out-of-hospital. The key, and I'll go through these real quickly, they're all pretty much the same. The first link, either in or out, is going to be recognition and prevention, and out-of-hospital is prevention. They have a little picture there kind of saying, seatbelts, things to do to prevent yourself from having problems, and then activation. They really stress high-quality CPR, and that's the key to all this is if you do need to do CPR, do it right. Pretty simple. Then some advanced resuscitation, post-cardiac arrest care. We always talk about ROSC, return of circulation, spontaneous circulation, and how do we get there? But afterwards, you got to make sure that you continue to care. It's not just make the shot, you got to keep playing afterwards. And then finally, recovery. We don't really do a whole heck of a lot of this in the EMS world, but this is a new link that they've added to both in and outside arrests, and to know that it's not done when the person starts to get better in the hospital. There's a long time to recovery. For our BLS providers, This is just a very basic, and we'll get into it a little bit more, but these are a little diagram that kind of breaks it down into 3 steps. It's also something they'll use in the for lay people to use as well, but big thing is to make sure you're safe, and that's something that we're all good at. Those of us in the hospital are probably less good at it than people who are on the front line who actually pay attention to that, so it's great. Step 2, make sure you're not alone. You don't want to be alone. Make sure you get some help. And then the last one is making sure that you're doing good quality CPR. Push fast, push hard, and it kind of gives you a little bit of how far to push, third of the chest depth, or about 2 inches, to make sure you're getting good CPR. Talks a little about infant CPR. We'll get to that in a minute. I'll go into more detail later on. Breaking down some of the pathways. Here is the pathway for a single rescuer. If you look at the level of evidence, it's a B rating. It's not great, but there is a higher recommendation. CPR should be provided to infants, and infants, if you can do it, if you have bystanders that are going to be helpful. Rescue vests are good, but if they're not going to do it, then compression only is great. I look at the picture on the right, and you'll notice that the biggest change from what was before is the number of breaths per minute. Before, it was not as many. It was like 15 to 20, and now they actually want you to breathe a little bit faster, 20 to 30 breaths per minute. 2 rescuers, very similar. Not much different than what I just mentioned before, but again, the big change in this one is going to be breathing a little bit faster than had previously been recommended. Here's the pediatric cardiac arrest pathway. You'll see that it looks very similar to the adult pathway. There's not a whole heck of a lot of difference. And then kind of going through, it does have your, is it a shockable rhythm? Is it not a shockable rhythm? The one change that I see this time, and we'll go into a little more detail in a little bit, is the epinephrine. Faster is better, sooner is better. So we'll talk about that here in a minute. But overall, there's not a huge difference in the pediatric cardiac arrest. And then they have a post-care. This is brought out. A lot of this is done after the fact, but there is some that can be done in the EMS world. Oxygenation. You don't want to slam a bunch of oxygen on your patient afterwards. I think the adult population was above 92, and the pediatric population, they want you in the range of about 94 to 99% for oxygen saturation. So if they're satting okay, you don't have to give them tons of oxygen. Monitoring, it goes into some depth later on past the EMS world of, central lines and telemetry, etc. But the biggest thing is to make sure you get resuscitation, you don't over-oxygenate them, and you move on. Thermal control is pretty important. Don't let them get too cold. You don't want their metabolism to be revved up from being too high. You don't want them to be too cold. So usually they're shooting for about, they write down here, 36 degrees to 37.5 degrees centigrade. You don't want them shivering. That kind of burns up more calories and causes more glucose to be burned up. All right, moving on. Oops. Looking at this pathway, this is kind of the prognostic. This, it's not really part of the pediatric world. It looks like my little box is covering up part of it, but it just says that it's not such a big part of the pre-hospital care, but it may be important later on. Dr. Zeeb actually mentioned this as well in the adult population, that long-term recovery or long-term expected recovery may dictate what we do in the pre-hospital world. They do mention that, again, past our EMS world, that patients may benefit from a rehab service or from neurological evaluation down the road, but for our standpoint, just something to know about that was been added to the policies and to the protocols. All right, let's start some of the nitty-gritty. Airway. So this is the airway section. There's some of the new recommendations, some of the new informations show that, an ET tube is really not any better than a supraglottic airway, which is really not any better than bagging. If you need more hands, bagging is going to take a whole person. So if you can put a ET tube in and you think you're good at it, then that might be something to do. The biggest thing is not to delay resuscitation by spending a lot of time on the airway. And also, we've noticed that people can have some low stats, and you don't want that to happen either. Other big news in the world is cuff tubes. That's changed a little bit. It's kind of been standard in the adult world, and many years ago, it was unheard of in the pediatric world, and it's become more and more used. And this latest rendition has really pushed using cuff tubes, and then making sure you inflate them to about 20-25 degrees of water and no higher. And they show that by doing this, you have less chance of having to replace the tube, and less chance of, and you don't have a lot of possibilities of having pressure damage to the airway. I think that was one of the concerns years ago. Lastly, cricoid pressure. That may be okay, so you're not going to blow up the but during intratracheal intubation, it is not recommended. It can interfere with view. They show down here from the, recommendation can cause some harm, so they really don't want you doing that. So cricoid pressure is besides when you're bagging, is not really set. The guidelines, they do go into sepsis a bit. There's a lot of question over whether, should I use saline, which I've used for years. There's some discussion about lactated ringers might be a better option of a choice. And recent studies show that there isn't really any better yet. So I will say yet, because there are some studies that they're looking at it. As of now, it's your choice, saline or lactated ringers, whatever you have. But as for down the road, there's some studies out looking at whether or not one might be better than the other one. So we'll have more information in the future. For this update, you can use either ones. The big thing is the bolus has changed. It used to be 20 per kilo. Now it's saying give 10 or 20 per kilo. And that's fine. You don't have to be stuck at one or the other. You have a little bit of wiggle room. The biggest thing is to make sure you check the patient between each bolus. So give them a bolus, look at them again, see if they're doing okay, if they need more. After you've done 2-3 boluses, then you can, and the kid's still not getting better, there's what's called fluid unresponsive, and at that point you can start thinking about pressors. My goal would be that you would already be at the end hospital by the time that you got to that many boluses. And it's not something that we're going to start hooking up drips in route. So I think we're good. If we can get up to a couple boluses, we should be at our endpoint, and most kids will respond pretty quickly to that. I'll throw this in there. Our new guidelines did talk a little bit about opiate overdoses. This actually is exactly the same as the adult chart. The new guidelines mention that. They say there is no pediatric data to support using Narcan or not using Narcan. I know we use it, and I am in full support of it, but American Heart did not come up with any recommendations for pediatrics, and just said use the adults. I know talking about Narcan, the guidelines just said we don't know. Nothing's proving that it's excellent, but it does seem to work, and I'm supportive of continuing to use it. All right, bradycardia pathway. I don't see a whole heck of a lot on here. They still have epi, so have atropine. If you look down the bradycardia pathway, a lot of it's about the same. You look at your level of recommendations, and they have a lot of level 1s of using atropine. If the heart rate's less than 60, you can start CPR, but not a lot of a lot of evidence to support this, but that is their recommendations currently, and nothing that I really want to jump on as being new to throw out to the guidelines. All right, pediatric tachycardia with a pulse. I think a lot of this stems to SVT. I know adenosine was mentioned in Dr. Zeeb's lecture. For the pediatric tachycardia, for the pediatric SVT, adenosine is still recommended. IV IO, IV is better, but if you have an IO, go ahead and use it. You can do vagal maneuvers. You can do synchronized cardioversion. I would say the first line would be, if you don't have access, would be vagal maneuvers if the kid is stable. If he's not stable, then I would jump right to synchronized cardioversion. But if he's stable, I would try the vagal maneuvers, and then you can jump to the adenosine. All right, jumping to some neonatal. Interestingly enough, our neonatal birth, about 1 in 10, this is interesting, about 1 in 10 kids will have a problem at birth. Babies will have a problem at birth. And the way the American Heart lists it is they'll have problems transitioning from a fluid-filled wound to an air-filled environment. Thought it was kind of funny how they mentioned it. What that means to us, what does that mean to a person getting called on the street? You know, that's 90% of kids are fine. 10% will have a problem. With all the prenatal care that is offered out there, prenatal ultrasounds, prenatal cardiac ultrasounds, the chance of one of us rolling across pulling up to a birth that happens to have complications is pretty low. It's not zero, but it's pretty low. So that's reassuring. If you look at the neonatal pathway, you can kind of walk through it, and I will kind of go through each point here in the next slide. The biggest thing is being prepared. They mentioned. So one of the recommendations, every birth should be attended by at least one person who can perform the initial steps of newborn resuscitation. Somebody who's responsible. And every breast should have a standardized risk factor assessment tool should be used to assess the potential perinatal risk. Basically, what that means is the Scout motto: be prepared. So be ready for complications. Our goal is that there aren't any. Our likelihood is that there aren't going to be any, but we should be prepared for it. Our guidelines look at 2 different ways to do chest compressions. For a single rescuer, they talk about doing the 2-finger technique, like in the top picture, of doing chest compressions. But they're also happy with doing the 2-thumb technique if you want to hold the baby, and your thumbs encircle around. Either way is fine, as long as you're compressing the sternum and making sure that you're getting a good chest rise, and we're getting blood circulating. It's user dependent. Here it kind of lists 2 people versus 1 person. It doesn't matter. I mean, if there's 2 people, you still have enough room there. You just want to do what you're comfortable with. They both work just fine. All right, so what are some baby pearls? And this I'll spend a little bit more time on. I already mentioned this before. Most kids are born fine. Most kids don't really require immediate cord clamping. I know they talked about get them out, put a clamp on there. You have a little bit of time. The biggest push now is to prevent hypothermia, and they talk about skin to skin with the mother. So give the mother the baby, let her go skin to skin, and you'll be doing well. Some of the data that we found so far is that skin to skin after birth can be effective in improving breastfeeding, temperature control, and blood glucose stability. Also found that it showed reduction in mortality, improved breastfeeding, like I mentioned, shortened length of stays in the hospital, and improved weight gain in some of the preterm or low birth weight. So rapidly getting the patient out, dry them off, skin to skin will help out. For babies who appear to have ineffective respiratory effort after birth, Stimulate. Been taught for years, warm, dry, stimulate. So basically what you want to do is you want to make sure that you give them a little tactile stimulation. They usually will cry at that point, and they'll start to pink up and they'll look much better. When kids were born, previously you would shove a suction canister in their mouth and start sucking everything out of it. Current recommendations says routine suctioning is not that important. You don't have to do it. So have the kid come out. You don't have to put a next bullet point. Don't have to endotracheal tube them. I know for some of the older folks, we used to intubate every single patient that came out that had just the inkling of meconium stain to their fluids. Not recommended. In actuality, if the child can be bagged, even if they have meconium in their fluids and they need to or could be bagged, that's fine. You wouldn't try to intubate them to suck it out unless they were obstructed. So you can suck the mouth out if you have a lot of fluid in there, but don't try to be aggressively sucking out the baby's airway. When the heart rate is low, if they come out, stimulate them. If it's not pinking up, then you can use a little bit of ventilation. The heart rate is probably the most effective indicator of ventilation. So if they're not moving air right away and their heart rate's staying low, then they might need some positive pressure. The next bullet point, and if that heart rate is less than 100 beats per minute after you've warmed them and stimulated them, as I just said, positive pressure, which can be 21%, it can be straight room air, will help out with kind of making that better. Next bullet point, if their heart rate's low and it remains less than 60 beats per minute after about 30 seconds of giving them that positive pressure, at that point you can start chest compressions with a ratio of 3 beats to 1 breath. Last couple of things, how do you get access to these patients? What's the best way? They're babies, they're small. When they come out and you've clamped that cord and cut the cord, you look at it, there's 3 vessels usually staring at you in the face. There's a big, huge vein staring at you and 2 arteries. So the umbilical vein is the recommended access of choice. If you don't have access to cannulating that or just have too many concerns, an IO can be done. It's not without complications when you put an IO in, but that is one of our accesses that's possible. And then lastly, persistent bradycardia. So you found the kid, you've bagged him with air, and you've had to start chest compressions, and you get your access and he's just still not coming up, then you can move on to epinephrine and follow the pathway. So this is fairly new. We talked about when do you give up, and I hate to say the word give up, but you go and you do all these things and you still don't have a heart rate. This is probably the hardest thing for anybody that's delivering a baby to talk about or to even think about. But at some point, it does become futile. So the American Heart came out and said, you've done all your resuscitation, you've done your suctioning and breathing, and you've given epinephrine, and you've done chest compressions, and you're just 20 minutes into it and you still have nothing. At that point, you can talk to the family, talk to your colleagues, and determine if the child is actually viable and should go on. This is a little bit of a change. In the past, it was 10 minutes, but at this point, their level of recommendation is a level 1, but it talks about, at some point, you can think about withholding or stopping. This comes out of, not just neonatal, but also pediatric resuscitations. Where's mom? So having parental involvement in the resuscitative care. And I think that's a big important thing. They've done studies and looked at this, and they find that it can benefit families if they're permitted to be present while you're doing the resuscitation. Some of the comments that families have made is that they feel that they felt connected, and the child actually felt their presence. And they felt more, I think, had better closure if it was a bad outcome, if they were there when everything happened. They do mention in the guidelines that a facilitator will help. A lot of times we don't have that luxury. I know in the hospital we'll utilize a social worker or a pastoral care. So it may not be the luxury that we have, but somebody who can kind of explain what's going on to the family and talk to them and be with the family. One of the big concerns we had, a couple big concerns that we had for having the parents present are, they're going to see me doing something wrong. And it turns out that's not really the case. And the other thing is they're going to get in the way. I've been in a bunch of resuscitations, and every once in a while the family is right there at the head of the bed, which can be a little bit in the way, but not a big deal. And for the most part, they don't. They want you to do a good job, obviously, and they're really happy and appreciative after the fact that they were there. And it's a plus. So I highly recommend, if you're on a scene and there's a child that needs resuscitation, have the family there available. Okay, so a couple more slides to kind of sum this up. Some of the new stuff and the old stuff. I wanted to contrast some of what changed in 2020 versus what happened previously. Currently, our new recommendations, and I alluded to this earlier, were 1 breath every 2 to 3 seconds, which comes out to 20 to 30 breaths per minute. In the past, it was saying, let's just do 1 every 3 to 5 seconds, which was 12 to 20 a second. And I think what they found on that is that, it was associated with higher rates of return of circulation, spontaneous circulation, and survival. They found that in the in-hospital cardiac arrest, there's really no data in the out-of-hospital cardiac arrest, but they can extrapolate it and standardize it for in or out-of-hospital. What else changed? Cuff tubes. So, in the past, like I mentioned before, it was no cuff tubes. Now they recommend to choose a cuff tube over uncuffed tube in all situations. And again, the pressure should be somewhere between less than 20 to 25 centimeters of water. The old recommendation was not as strict about the cuff tubes. They kind of said, yeah, both cuffed or uncuffed tubes are fine, but now they're really pushing the cuff tubes. The reason being, it will down the road decrease the need for tube changes and reintubations, and can decrease the chance of aspiration. One of the concerns in the past was some subglottic stenosis that I mentioned earlier, but they really found that it's pretty rare, so it's not really a big problem. Cricoid pressure, I've already mentioned this, was not recommended. In the past, they said there was insufficient evidence to recommend, so now they just are a little stronger of a recommendation and said, no, we're not going to do it. They found that it actually reduces the success rate of intubation and doesn't really help with regurgitation. So if it's not going to help, don't do it. Epinephrine, I know Dr. Z mentioned epinephrine, any kind of studies that prove that it's really good, not really good. We don't have a lot of evidence for that. The big change that we did find is they do recommend it within 5 minutes. The old recommendation was it was reasonable to give epinephrine. Now they're saying if you're going to give it within 5 minutes from the start of chest compressions. They found that every minute of delay in administration of epinephrine, there was a significant decrease in the return of circulation. There's a decrease in survival to 24 hours or survival to discharge. And they found people had a little bit better neurological outcomes. So if we're going to do epinephrine, which I do recommend we do, give it early. Don't wait. Fluids. We talked a little bit about this already. The biggest change was before in the past they talked about, give 20 per kilo. Now it's 10 to 20 per kilo. The big concern about the fluids was having fluid overload. I think they were finding some people were getting too aggressive with the fluids and finding some fluid overload. So trying to be a little less aggressive. Fluids are still good. Please give the fluids, but we don't have to slam them with so much. And the last part was the skin to skin, and I kind of already mentioned that, being increasing some of the glucose control, some of the longer term outcomes on baby, and it's also good for bonding, and it keeps the kid at better normothermic. So early skin to skin if you're out there delivering babies. From that, I think that's it. Dr. Zeeb told me I had to keep it under 30 minutes, or right at 30 minutes, so I think we're pretty close to that. If there's any questions or concerns, please let me know, and I'd be happy to answer them. Thank you.